Inflammatory myopathies. Muscle tissue. Skeletal muscles are very peculiar sites because they are one of the few areas of the body without any immune system infiltration or resident macrophages. It's made up by bundle composed of syncytia of myocytes. In normal conditions, as you can see on the right, nuclei are located at the periphery of myofibers, while in conditions of damage, when the muscle tries to regenerate itself, they are displaced into the center. In the middle of the bundle we have the artery, vein, nerve and lymphatic vessels supplying it, while the capillaries surrounding it in its periphery and in between myofibers. The perimysium is the area surrounding the bundle and can be one of the sites involved in inflammatory diseases. The location of the inflammatory infiltrate can help to diagnose the different diseases at histology. In polymyositis, there is an inflammatory infiltrate inside the myofiber, central, while in the other diseases there is an infiltrate outside of the fiber, within the perimysium and around the blood vessels, peripheral. Myofibers are MHC negative. When healthy, they have no MHC class 1 or 2 expression. The expression of these proteins is always a sign of pathology. Myofibers are very specialized cells for muscle contraction. Non-physiological conditions such as the expression of MHC class 1 molecules can be very stressful for these cells, giving rise to an overload of the unfolded protein response UPR system, and may require the activation of autophagy for survival. Remember also that autophagy is used by muscles also to decrease the size of their cytoplasm in different conditions. When you train cells, cells do not increase in number. There is no adaptive hyperplasia in muscles, but they increase only in size, a process known as hypertrophy. If instead you starve for a couple of days, your muscles will undergo autophagy to provide the body with enough energy for survival. We can use them as a reservoir of proteins and amino acids. When the muscle is injured, it gets activated by inflammatory signals in order to regenerate itself. We have two different kinds of fibers. Type 1 are the slow aerobic fibers that predominantly use oxygen and myoglobin, while on the contrary, type 2 are fast and anaerobic. The sensitivity of these two kinds of myofibers to different oxygen levels is very different. Cells that are much more able to perform with an anaerobic profile are also less sensitive to hypoxia. There are many agents that can damage the muscles, among which the most important are viruses and bacteria. Drugs can also be important causes, and we will discuss about necrotizing myopathy following the use of statins. Corticosteroids can give rise to muscle hypertrophy, which combined with inflammatory myopathies can be severely debilitating for patients. Interferon in general damages the muscles, and it can also be triggered by viral infections, so it can also be an indirect cause of muscle damage by viruses. There are situations related to the production of TNF alpha. Its first name was indeed cathexin, such as tumors and inflammatory disorders with the production of many cytokines that can trigger hypercatabolism of the muscles. So, the agents that can damage the muscles are infectious agents and subsequent inflammatory response. So, bacteria like Staphylococcus aureus, Borrelia burgdorferi, viruses like Coxsackie, Parvovirus B19 and Ecovirus, and parasites like Toxoplasma gondii. Drugs are statins and fibrates, corticosteroids, and interferon alpha, and hypercatabolism due to TNF like in tumors and inflammatory disorders. Epidemiology of inflammatory myopathies. In general, inflammatory myopathies are rare disorders. Incidence is 1 over 10 million per year, and prevalence is 6 over 1 over 10,000, around 100,000, around 1/10 of other connective tissue disorders like SLE. Male to female ratio is 1 to 2. The mean age of onset is 50 years in young adults. There aren't many risk factors other than tumors and HLA-D3, which is common for autoimmunity in general. Dermatomyositis is correlated with tumors, also detectable ones, and for such reason, every time you diagnose a patient with dermatomyositis, you must follow the patient strictly for the following 2 years. Inflammatory myopathies. They are autoimmune diseases of the skeletal muscle. Myositis-specific autoantibodies have an uncertain role. There is a frequent overlap with other connective tissue diseases. The main clinical subsets are polymyositis, dermatomyositis, inclusion body myositis, and necrotizing myopathy. Pathogenesis is not clear, and what I present today is a hypothesis that is still far from being demonstrated. For this reason, also the results of therapy are quite bad, and often these diseases remain undiagnosed for long periods of time, and therapy starts very late, giving poor results. The beginning of everything, there are exogenous triggers that damage the muscle, like in statin-related necrotizing myopathy, that is an autoimmune condition. Statins are the initial cause of damage to the muscle. In other diseases, we think that at the beginning there are infections, viruses, or bacteria. After this initial damage, the immune system is recruited in the muscle where it normally does not reside. It tries to clear the infection, eat the damaged myofibers, and produce factors that trigger the repair of the skeletal muscle. We know from experiments in vitro that if you don't have a proper immune system when the muscle is damaged, it will never be repaired because myofibers require factors that are secreted by immune cells in order to regenerate. The immune system that arrives at the site of damage indeed not only produces factors that sustain the resolution of the damage, but also factors that activate the myofibers. We have cytokines like TNF alpha, IL-6, and interferon alpha and beta produced by peripheral dendritic cells, which activate the catabolism of myofibers. Stressed myofibers start to produce MHC molecules, causing an overload of the unfolded protein response and activating further catabolic pathways that modify their content. At such point, the immune system is never able to stop the response and remains instead amplifying the damage by producing more factors that sustain the local inflammation. So it's a vicious cycle. Myofibers also start to produce antigens that are typical of embryonic life, which are generally not present in a healthy skeletal muscle. During adult life, skeletal muscle does not normally regenerate, and for this reason, regeneration is accompanied by expression and upregulation of molecules that are typical of the embryonic life. Ok, fra poco. The immune system, after this initial damage, the immune system, myofibers also start to produce antigens that are typical of embryonic life, which are generally not present in a healthy skeletal muscle. During adult life, skeletal muscle does not normally regenerate, and for this reason, regeneration is accompanied by expression and upregulation of molecules that are typical of the embryonic life, against which we have no strict tolerance. No cells that arrive to sustain regeneration in the end perpetuate the damage. Why does the immune system activate the catabolism of the myofibers? Because it produces the cytokines that typically induce hypercatabolism, like TNF alpha, IL-6. These are inflammatory disorders. CRP is very high, not like in SLE, and other cytokines. The myofibers have their own stem cells inside their structure, located close to the membrane of the fiber. They are known as satellite cells. In healthy skeletal muscle, they are quiescent. As soon as the immune system arrives in the muscle, it produces factors that activate satellite cells for regeneration, but these satellite cells have been clearly demonstrated to be able to undergo differentiation towards cells other than myofibers, but also fat or collagen producing cells, fibroblast like. If something goes wrong in the information that the immune system gives to the satellite cells, this, instead of undergoing differentiation towards muscle, will then cause the muscle to be substituted by fat and fibrotic scars if the inflammation is long-lasting. There are also other cells involved like fibroidogenic precursors and pericytes. So in the pathogenesis we have typical cytokine cells and myocytes. Typical cytokines are interferon alpha and beta produced by Peripheral dendritic cells, chemokines that trigger muscle hypercatabolism, TNF-alpha and IL-6, chemokines, fibrosis-inducing agents like TGF-beta cells, antigen-presenting cells, and TCD8 positive T cells and CD4 lymphocytes in polymyositis and B lymphocytes in dermatomyositis, and myocytes, where we have expression of MSC1 and 2 molecules, and aberrant processing and de novo expression of cellular constituents. Polymyositis is the prototypical inflammatory myopathy disease. It has a non-specific onset with fatigue and symptoms of inflammation and anorexia, common to many connective tissue diseases. The main predominating symptom is muscle weakness, which has to be symmetrical since it is a systemic disease, and in the classical form it affects proximal muscles. This helps in differentiating polymyositis from neuropathies, which typically have involvement of the distal muscles. It starts from the lower limbs and typically progresses to the upper limbs, neck and pharynx in the late phases. As a difference with myasthenia gravis, ocular muscles are always spared. The disease does not present with pain but only weakness. Patients are typically adults in their 40s-50s who complain of fatigue and inability to climb the stairs, get up from a chair or from the floor, and tripping because of lower limbs muscle deficit. The patient also feels sick because of the ongoing inflammatory process and cytokine release. Deficit of the upper limbs brings to difficulty in combing or grasping objects placed on ice shelves, difficulty in buttoning up clothes, or turning keys in the keyhole. Dysphagia and dysphonia can be present. Dysphasias with deficits in neck extensor muscles give rise to a typical sign that is the dropped head syndrome. These are the typical manifestations of polymyositis, but the disease can present with also other signs and symptoms which are less typical. Have rheumatoid arthritis like arthritis, gastrointestinal manifestations like GERD, dysphagia, which makes polymyositis similar to another autoimmune condition dominated by GI symptoms, which is scleroderma. Indeed, there is an overlap between polymyositis and scleroderma, and both can present together. We have respiratory manifestations, so respiratory failure due to myasthenia and alveolitis, which is very rare, and pneumonia epigestis. In the heart involvement is frequent and underestimated, so it's subclinical. Inflammation of the heart can give rise to arrhythmias because inflammation due to damage to the myofibers will block the electrical conduction in the heart. Arrhythmias are a typical symptom of myocarditis, which is rare. Pericarditis, especially present in patients with an overlapping SLE, especially if anti-SRP positive, and Raynaud's phenomenon, which is a vasospasm typically associated with systemic sclerosis. Dermatomyositis. It has all the characteristic manifestations of polymyositis plus cutaneous manifestations, which are quite typical of the disease. Muscle weakness and cutaneous manifestations can appear together, or one can precede the other also by many years. A patient can present with a clinically defined polymyositis, and at the biopsy you find characteristics typical of dermatomyositis, and then he will develop cutaneous involvement after some years. Cutaneous manifestations are onset can be variable with respect to muscle weakness. Complete picture is frequently associated with antibodies anti-Me2. Clinical variants are itchy and lilac pink color rash. So we have a periorbital and heliotrope rash located around the eyes and can be triggered by exposure to sunlight. At the level of the cheeks, nose, and also involving the nasolabial region, which helps to distinguish it from the butterfly rash of SLE, as seen in the comparison below. We have a re-rash on the chest, again due to sun exposure, a shoal sign, an ulster sign on the lateral surface of the thighs and hips. We have papules and plaques of Gottron, purple or erythematous lesions with desquamation and hyperkeratosis. Can look like the discoid lesions in SLE, although discoid lesions are less hyperkeratotic, more similar to psoriasis lesions, although they are located in very particular areas. Sites are bone prominences, especially in the hands, metacarpophalangeal, proximal interphalangeal, and distal interphalangeal. The sign of Gottron, which is quite characteristic, We have a macular erythema on prominences and external surfaces. We have evolution in atrophic and hypopigmented lesions with telangiectasias, so capillary dilations. We have panniculitis and hyperplasia of the nail cuticle, which is again very characteristic. Subcutaneous manifestations are calcifications, which are late phase manifestations due to chronic inflammation and long lasting panniculitis. They can be very relevant for the patient and extend in vast areas as seen in the X ray. These are more frequent in the juvenile onset disease. We will not cover the pediatric disease, which has some common and also some peculiar features. Tumors. The risk of tumors in the 2 years following diagnosis is 6 times that of the general population. Associated tumors are the classical ones, more commonly found in the general population. Have ovarian carcinoma, GI carcinomas, lung cancer, mammary cancer, and non-Hodgkin lymphoma. Nowadays, we perform a total PET-CT at diagnosis and then every 6 months for the following 2 years. So you see here, heliotrope rash, Scholl sign, V rash, Ulster sign, lupus, dermatomyositis, plaques of Gottron, and sign of Gottron. Inclusion body myositis can be discriminated by histology very easily, but also clinically, because it's characterized by late onset, more than 50-60 years, and a slow progression. Does not have the typical flares or remission phases of the other diseases, but a slow and continuous progression of muscular deficit. Inflammation is also less prominent than in the other diseases, which consequently also makes a response to corticosteroids and immunosuppressants very poor. It's frequently associated with other autoimmune diseases. The involved sites are finger flexors, very typical, external muscles of the legs, femoral quadriceps. Necrotizing myopathy is related to the use of statins, which are only the initial triggers of the disease, which then progresses because of immune system chronic damage. It's an autoimmune disease with muscle necrosis due to an immune system's action. Necrosis of the muscle fiber is prominently found at biopsy together with poor inflammatory infiltrate, poor expression of MSC class 1 molecules. The response to treatment steroids is low and poor. The clinical manifestations are similar to polymyositis, frequently associated with autoantibodies, anti-SRP+. Diagnosis, medical history, and clinical examination of muscle weakness, typically by a consulting neurologist. Laboratory tests can help you identify muscle necrosis, creatine kinase and LLDH, inflammation, ESR and CRP, autoantibodies. You have myositis-specific autoantibodies, anti-Jo1, anti-SRP, and anti-MICHU. About 50% of patients with PM or DM have myositis-specific antibodies, so when the clinical examination and testing suggest the possibility of these diseases, their presence can be strongly suggestive of a correct diagnosis. They also have improved our understanding of myositis by leading to the identification of certain clinical patterns, because their presence is associated to peculiar clinical features. We're not sure what is the mechanism behind this association. And when we have myositis associated autoantibodies, remember that they exist. We have electromyography as another laboratory test. We have imaging. MRI is efficient to visualize muscle, and imaging is also used to search for occult malignancies. So we use total body CT, colonoscopy, pelvic echography. Muscle biopsy is important to discriminate between the different diseases. Criteria. As in the other diseases, there are criteria which are not for diagnosing the disease, but for stratifying patients for clinical trials and comparisons. They are quite unspecific. We have proximal muscle weakness, which must be symmetric, myositis at biopsy, increased circulating muscle-derived enzymes, so CK, aldolase, LDH, and also AST, ALT, which can come from muscle cells, typically EMG modifications, characteristic rash, only valid for dermatomyositis. So the first four criteria are typical of both polymyositis and dermatomyositis. while the fifth is present only in dermatomyositis. So remember, there are proximal muscle weakness, which must be symmetric, myositis at biopsy, increased circulating muscle-derived enzymes, typical EMG modifications, and characteristic rash. At EMG, healthy muscle at rest, no electrical activity. At minimum effort, um, we have motor unit potentials of intermediate amplitude and duration. At maximum effort, we have interference pattern with rapid alternation of several phases and recruitment of all motor units. EMG myositis due to inflammation and loss of muscle fibers. They help in distinguish between myositis and neuropathies. At rest, you already have electrical activity, fibrillation potentials. At minimal effort, you have motor unit potentials of low amplitude due to decreased number of recruited fibers, increased number of potentials phases due to decreased lifespan because of early exhaustion, and early interference pattern. Minimal effort mimics a maximal effort pattern of healthy muscle. Histological characteristics are: few characteristics of damaged muscle found at histology are centrally located nuclei. If a muscle is healthy, its nucleus is at the periphery. This also helps if you do not see the damage itself mediated by the immune system, but you find only central nuclei, you know that there has been damage to the muscle and is trying to regenerate. You have expression of MSC class 1 and 2 molecules, MSC1 by the myofibers themselves, and while MSC2 is brought to the site of damage by antigen-presenting cells by positivity to immunohistochemical staining. You can also see myofibers very heterogeneous in size due to various phases of necrosis, atrophy, and eventually fibrosis. Type 1 fibers die more easily, while type 2 will substitute them, therefore changing their ratio within the muscle. Muscles involved in these diseases are typically mixed fiber muscles, and there is a shift towards type 2 prevalence. So there is type 2 prevalence. The different fibers also tend to cluster together, thus forming islands of type 1 fibers and islands of type 2 fibers. This is called type grouping, and it presents at biopsy as a loss of the characteristic mosaic appearance of muscle tissue. There is activation of the endothelium of capillaries and an inflammatory infiltrate of lymphocytes and monocytes or activated satellite cells, which are not distinguishable from inflammatory cells. There is no clinical histological correlation between muscle weakness and histological alterations. We are not exactly sure of which is the mechanism inducing muscle weakness. One major distinction is that in polymyositis, the inflammatory infiltrate is mainly located in the endomysium in between the fibers. It's characterized by T lymphocytes, CD4 positive and CD8 positive, and macrophages and dendritic cells. You can also see collagen deposition in between the fibers, which should not be there. It is an ongoing pathological process. In dermatomyositis, instead, there are completely different histological characteristics because the inflammatory infiltrate never reaches the fiber. It's located in the perimysium around the blood vessels, which in fact are at the periphery of the fibers. It's a vasculitis with activation of pericytes and sign of capillaritis, inflammation of the capillaries, with complement deposition and microvessel damage. It's a perivascular inflammation with an infiltration of B lymphocytes mainly together with CD4 positive T cells, macrophages, and dendritic cells. These characteristics are pathognomonic. Also, MSC class 1 expression can be present, but is limited only to the fibers close to the perimysium in the periphery. In inclusion body myositis, there are characteristic pathognomonic inclusion bodies made of similar Alzheimer amyloid plaques inside and around the myofibers. It's the only disease of muscles with deposition of beta amyloid-like structures. Inflammation is not so evident on biopsy, and in fact response to anti-inflammatory drugs is not good. Necrotizing myopathy presents with necrotic myofibers which are not evident in the other diseases. Necrosis is demonstrated by loss of integrity of the cytoplasm of the fibers and appears vacuolated, patchy in color with pale areas. Cell death is not so easy to recognize in such tissue because there are syncytia, so it's not a single mononucleated cell that dies, but there is a progressive degeneration of the cytoplasm. Autoantibodies, there are specific correlations between the positivity to certain autoantibodies and particular clinical presentations. These shown in the figure are those the three you should remember: anti-Jo1, that is anti-synthetase, anti-SRP, and the anti-MYD2. Anti-synthetase, anti-Jo1 syndrome, is characterized by muscle weakness plus mechanic hands, which are very dry hands with a peculiar rash and thickening of the palms without any obvious cause like working with your hands. We have dominant interstitial lung disease, so we have to make a differential diagnosis with systemic sclerosis because it typically can have lung involvement, GI symptoms, and Raynaud's phenomenon, arthritis, and fever. This is the best defined of the three syndromes. The CT shows diffuse fibroids found in a patient with antisynthetase syndrome. Anti-SRP syndrome is associated with cardiac involvement, and anti-Mitsu syndrome is associated with skin involvement, with typical dermatomyositis, rashes, and cuticular overgrowth. Not all dermatomyositis patients are anti-Mitsu positive, but those that are typically have these features. So, anti-Mitsu, skin involvement, typical dermatomyositis rashes, and cuticular overgrowth.